Finals SAQ57, Major Hemorrhage and Trauma. A 45-year-old man has a major hemorrhage following significant trauma and is admitted to your emergency department. He does not have a head injury. A. Give one definition of major hemorrhage. Either loss of more than 1 blood volume within 24 hours, 50% of total blood volume loss in less than 3 hours, bleeding more than 150 mL per minute, or bleeding that results in systolic blood pressure of less than 90 mmHg or heart rate more than 110 beats per minute. B. What are the principles of management of major hemorrhage in this patient? This is a medical emergency. Call for help. Follow ABCDE trauma team management approach. Assess and treat simultaneously as issues are reviewed. Recognition of major hemorrhage, concealed or revealed, may have multiple sources. Assess heart rate, blood pressure, respiratory rate, capillary refill time, conscious level and pallor. EFAS if unstable, CT if stable for transfer to identify source. Start to control major hemorrhage. Institute major hemorrhage protocol. Airway and breathing. Provide 100% oxygen. Definitive airway if indicated. Cervical spine control. Correct immediately life-threatening conditions such as tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, airway disruption or obstruction, cardiac tamponade, etc. Circulation. Early hemorrhage control with direct or indirect pressure, elevation, tourniquet, immobilization and splinting until definitive intervention. Consider use of topical hemostatic agents like Celox. Large bore IV access. Intraosseous or large bore central access if peripheral IV not feasible. Avoid insertion distal to a source of hemorrhage. For example, avoid femoral vein in abdominal trauma. Resuscitation, theatre transfers and surgery should not be delayed for central or arterial lines. Take blood for cross-match, coagulation, FBC, urea and electrolytes, ABG and lactate. Repeat investigations during resuscitation to guide ongoing management. Use point-of-care testing. Use pressure infusers, blood warmers and cell salvage if applicable. O-negative blood should be immediately available in clinical area. This can be used if there is a delay in blood issue from blood bank. O-positive blood may be used as the patient is an adult male. Switch to type-specific or cross-match blood at the earliest opportunity. Transfuse warm packed red blood cell, FFP, and platelets in a 1:1:1 ratio to replace volume loss. The patient is at risk of lethal triad of acidosis, coagulopathy, and hypothermia. Keep the patient warm and treat coagulopathy and acidosis. Establish whether the patient is taking drugs that interfere with coagulation. Discuss with hematologists and reverse as indicated. Consider tranexamic acid. Consider PCC, recombinant factor 7A, and warm whole blood in resistant coagulopathy. Discuss with hematologists. Do not give crystalloids unless profoundly hypotensive and no blood products imminently available, or if the patient refuses blood transfusion, to prevent worsening dilutional coagulopathy or hyperchloremic acidosis. Permissive hypotension while patient is actively hemorrhaging. Transient use of vasopressors can be considered in life-threatening hypotension while volume replacement is ongoing. When hemorrhage is controlled, carefully resuscitate to more normal tensive blood pressures to optimize organ perfusion. The shorter the period of permissive hypotension, the better the organ perfusion and morbidity. Until major bleeding has been stopped, volume resuscitation should be titrated to maintain palpable central pulses, SPP of 80 to 90 mmHg, MAP of 50 to 60 mmHg, and diastolic pressures of 25 to 35 mmHg. Elderly may need a higher blood pressure. Monitor resuscitation with POCTs. If HP is less than 7 grams per deciliter, administer packed red blood cells guided by the rate of blood loss. Aim for HP of 7 to 9 grams per deciliter. More than 8 grams per deciliter if there is cardiac morbidity. If INR more than 1.5, give FFP 15 to 20 mL per kg. If fibrinogen less than 1 gram per liter, give 2 packs of cryoprecipitate. Alternatively, fibrinogen concentrate. If platelets are less than 50, give 1 adult therapeutic dose. Catheterize to monitor urine output to guide fluid management. Consider calcium chloride, 10% 10 mL every 4 units packed red blood cells, or if hypocalcemia, correct hyperkalemia. D. There is no head injury. Monitor neurological status as an indicator for CVS stability. Give paracetamol and cautious opioid-based pain relief as required. E. Full exposure to check all sources of bleeding. Initiate patient warming. C. What complications might follow a massive blood transfusion? This may be classified as early and late complications. Early complications includes hemolytic reaction, for example, ABO incompatibility, non-hemolytic febrile reactions due to reaction to donor leukocyte antigens, allergic reaction due to recipient IgE versus donor proteins, TRALI due to donor leukocyte antibodies reacting with HLA and HNA in recipient, SIRS due to bacterial contamination, TACO, hyperkalemia, citrate toxicity and hypocalcemia, acid-base disturbances, hypothermia, air embolism, thrombophlebitis, and dilutional coagulopathy if other blood components are not given appropriately. Late complications includes infection, delayed hemolysis, immune sensitization, transfusion-related immunomodulation, transfusion-associated graft-versus-host disease, and post-transfusion purpura. Chairman report, 85.3% pass rate. This important topic was generally well answered. Additional information. Describe the ATMIST pre-alert communication tool. This consists of age and name, time of incident, mechanism of injury, injuries from top to toe, vital signs and treatment. This is an advanced warning and concise communication tool to pre-alert the ED to allow the team to prepare before the patient's arrival. Consider also including estimated time of arrival, mode of transport, and specialist resources required to be standing by. What are the 4 phases in the ATLS framework? This includes primary survey, resuscitation, secondary survey, and definitive care. What are the principles of the primary survey and resuscitation? C. Catastrophic hemorrhage control via direct pressure or tourniquet. A. Maintain airway patency and control cervical spine. Breathing. Identify and treat chest injuries and ensure oxygenation and ventilation. Circulation. Identify causes of shock and treat appropriately. Disability. Perform rapid assessment of neurological function. Exposure. Ensure full exposure of patient while preventing hypothermia. What are the principles of secondary survey and resuscitation? The secondary survey requires a systematic head-to-toe examination of the patient. It also includes management of peripheral injuries, ECG, complete neurological examination, formal orthopedic review, urinary catheter, and ASEA chart completion. The secondary survey often occurs outside ED, after resuscitation, surgery, or transfer to critical care. Classify shock. Shock may be hypovolemic, cardiogenic, obstructive, or distributive. Examples of hypovolemic shock includes hemorrhage, burns, and interstitial losses. Cardiogenic shock may be due to myocardial event, such as injury and ischemia. Obstructive shock may be due to cardiac tamponade, tension pneumothorax, or massive PE. Distributive shock includes neurogenic, septic, or anaphylactic. What are the weaknesses of the ATLS grade 1 to 4 classification for shock? Based on Mutual M. et al. Article in 2014, fewer than half of European ATLS instructors declared they would use this tool. Certain drugs being cold and some pre-existing medical conditions may lead to overestimation of blood loss. The tool also underestimates blood loss in children, pregnancy, blunt trauma, and athletes. What is the shock index? This is heart rate divided by systolic blood pressure. Shock index of more than 1 can help identify shock in patients with apparently relatively normal physiology. What are the goals of resuscitation? This includes systolic BP of 80 to 100 mmHg, MAP of more than 80 mmHg in head-injured patients, heart rate less than 120 beats per minute, SpO2 more than 95%, Hb of 7 to 10 grams per dl, INR of less than 1.6, lactate of less than 4, base excess of more than -6, fibrinogen of more than 1.5 grams per liter, platelet more than 50, pH more than 7.2, core temperature more than 35 C, and ionized calcium more than 1.1 millimoles per liter. What would be the appropriate BP target if the patient had traumatic brain or spinal cord injury and ongoing hemorrhage? BP target depends on dominant condition. If hemorrhagic shock is predominant problem, restrictive volume resuscitation should be employed. If traumatic brain injury is predominant issue, a less restrictive approach, targeting SPP of 100 to 110 mmHg and MAP of 80 mmHg or more, should be used to maintain cerebral perfusion prior to surgery. What further steps should be undertaken if the patient does not have a sustained improvement after blood product resuscitation? Definitive management of their hemorrhage should be undertaken, either via surgery or interventional radiology, with ongoing correction of coagulopathy and resuscitation to maintain goals of resuscitation. Trauma team leader and surgeon must decide if the patient will go straight to theatre or undergo CT scan. This will depend on stability of the patient, but unless life-saving surgery is required immediately, the patient generally benefits from CT scans. Consider resuscitative endovascular balloon occlusion of the aorta as a temporizing measure prior to definitive management of non-compressible uncontrolled torsal hemorrhage. Compare and contrast advantages and disadvantages of ultrasound versus CT scan in trauma patients. Ultrasound is indicated for screening free fluid in unstable patients. Advantages includes fast, sensitivity of 83 to 87%, can detect free fluid and some solid organ injury. Disadvantages: operator dependent, misses diaphragm, bowel and some pancreatic injuries, and may delay CT scan. Indication for CT scan is diagnosis of organ injury in hemodynamically stable patients. It is more specific for injury, 92 to 98%, and also demonstrates perforation. Disadvantages: it takes time and involves transfer away from resuscitation room. Summary of NICE guidelines on imaging in major trauma. Patients with suspected chest trauma or suspected hemorrhage, perform imaging urgently. Images should be interpreted immediately by healthcare professional with training and skills in this area. For patients with suspected hemorrhage and hemodynamic instability who are not responding to volume resuscitation, limit diagnostic imaging such as chest X-ray, pelvic X-ray or fast scan to the minimum needed to direct intervention. For patients with suspected hemorrhage who are responding to resuscitation or have hemodynamic normal status, consider immediate CT scan. Use whole body CT in adults more than 16 years old with blunt major trauma and suspected multiple injuries. Fast scan in major trauma patients. Do not use fast or other diagnostic imaging before immediate CT or as a screening modality to determine the need for CT. A negative fast scan does not exclude intraperitoneal or retroperitoneal hemorrhage. What are the principles of damage control resuscitation, DCR? DCR is a treatment strategy that aims to preserve life in bleeding trauma patients by stopping hemorrhage and proactively countering the lethal triad of hypothermia, acidemia, and coagulopathy. This focuses on initial hypotensive resuscitation, early use of blood products to limit or halt the progression of the lethal triad. It involves the postponing of definitive repair or fixation until patient has been adequately resuscitated. Key elements of DCR includes hemorrhage control and restoration of perfusion via damage control surgery, DCS, hemostatic resuscitation to prevent and treat trauma-induced coagulopathy, and permissive hypotension. What are the phases of DCR? Phase 0, recognition, rapid transport to hospital theatre and start of resuscitation. Phase 1, DCS and continued DCR. Phase 2, ICU-based physiological and biochemical stabilization. And Phase 3, return to theatre for definitive repair of injuries. What are the principles of DCS? DCS involves an abbreviated operation to control life-threatening injuries and restore physiology rather than correct anatomy. The goal is to preserve life. DCS consists of 4 key principles: hemorrhage control, control of contamination, protect the patient from further injury, and temporary closure. The later DCS is applied, the less successful the outcome. Investigations should only help identify which body cavity to open. If physiological exhaustion occurs, consider DCS. If patient has normal physiology, or responds promptly to resuscitation, consider definitive repair. Typical DCS procedures includes resuscitative laparotomy, resuscitative thoracotomy, pelvic packing, junctional surgery, and external fixation of fractures. More than one surgical team may operate simultaneously. Patients should be positioned and skin prepared to enable extension of the initial incision to another body cavity or junctional zone. DCS procedures should last less than 60 to 90 minutes. Resuscitation and correction of physiology should continue in the ICU thereafter. Describe the principles of Snapchat. This is a mnemonic that aids communication between surgical teams and anesthetists, for example, every 15 to 20 minutes, covering surgical progress and systolic BP, N for number of blood products, A for ABG, coagulation and temperature, P for plan until next interval. What are the principles of damage control anesthesia, DCA? Essentials includes airway and ventilator management, RSI and titration of ventilation, control of bleeding, deliberate hypotensive resuscitation, maintenance of blood composition, preservation of homeostasis with normothermia and restored and sustained end organ perfusion, analgesia and sedation. Aim to arrest lethal triad while ensuring cardiorespiratory stability and adequate analgesia and sedation. Interventional radiology procedures may take place in a remote location, hence usual considerations of remote site anesthesia apply. Airway. Adequate pre-oxygenation. Consider HFNC during pre-ox. Gentle assisted ventilation. Avoid inflating stomach. Jaw thrust to minimize cervical spine movement. If inducing for life-saving hemorrhage control surgery, patients should have their skin prepared and draped, and surgical team ready to put knife to skin immediately after intubation. Avoid instrumenting nasopharynx, nasopharyngeal airways, and nasogastric tubes in head injury. RSI with manual inline stabilization, two-handed cricoid pressure anterior and posterior, ketamine, fentanyl, and rocuronium unless contraindicated. Video laryngoscopy with hyperangulated blade or direct laryngoscopy and bougie standby if there is a lot of bleeding. Follow DAS algorithm. When performing manual inline stabilization or placing heart collar, no patient should have their head or neck forced into a neutral spine position, and no deformity should be reduced. Large cuffed single lumen ETT should be used. Avoid double lumen tubes due to added complexity. If one lung ventilation needed, use bronchial blocker or advanced single lumen tube endobronchially. Pass an orogastric tube to empty the stomach prior to extubation if this is intended. Breathing. Initially limit intrathoracic pressure to avoid further compromising a shock circulation, as increased ITP reduces venous return, preload, cardiac output, and MAP. Suggested starting parameters: FiO2 1, rate of 10, VT of 5 to 6 mL per kg, PEEP of 0 to 4, aim for oxygenation. As circulating volume expands, minute ventilation and PEEP can be increased, and FiO2 reduced to more normal levels. In the event of unexplained hypoxia and high inflation pressures, consider tension pneumothorax and chest tube insertion. C. A primed rapid infuser should be connected to a large bore cannula, giving volume to compensate for anesthesia and release of any tamponade. Previous principles discussed in B applies. Constantly re-evaluate. When bleeding is controlled, slow down rate of blood product infusion to avoid fluid overload. Assist the surgical team to recognize and appreciate the magnitude of hemorrhage and understand the need to maintain a dynamic plan. Transthoracic echo can be useful to assess the fluid status of the heart chambers for those trained in its use. In the event of unexplained hypotension and tachycardia, consider hypovolemia, pneumothorax, pericardial tamponade, or retroperitoneal vessel injury. In the event of unexplained hypertension, consider pain, raised ICP, and traumatic disruption of thoracic aorta. D. Maintenance of anesthesia. Volatile maintenance is recommended over TIVA to avoid additional workload in changing syringes. Target MAC of 0.4 to 0.6 with 50 microgram fentanyl boluses to provide simple CVS stable anesthesia. Fentanyl provides vasodilation to aid replacement of lost circulating fluid and lactate clearance. Beware that large doses of fentanyl can cause hemodynamic instability. Other analgesic options include ketamine, paracetamol, and regional anesthesia as appropriate. Hematology. Although patients may initially be hypocoagulable, they often become progressively hypercoagulable. VTE prophylaxis should be instigated early when warranted. Antibiotics are determined by local policy depending on incision. If pH less than 7.1, consider sodium bicarb. What are the principles of hybrid resuscitation? Hybrid resuscitation acknowledges the need to reduce the period of hypotension during permissive hypotension, partially restoring BP after 1 hour, even if definitive hemostasis is not achieved. This provides a greater degree of tissue perfusion prior to complete surgical hemostasis. Thank you.